All right, so good afternoon. Today's topic for the day teaching is on intra-abdominal sepsis. It's a very broad topic, as some of you just pointed out. We won't be able to look at all of it in detail, but what this topic is about, to get you an overview of what it is. You've been on this unit for some time now, so you know that we see this very often, and understanding what we can do as doctors working in intensive care when we are sort of faced with patients with intra-abdominal sepsis. So what we're going to cover is some sort of broad way of classifying it. It's important that we know what are the bugs involved, what's the microbiological aspects, because you might have noticed that during the MDTs, the microbiology consultants will give us useful advice based on that information. A small sort of overview of brief overview of the pathogenesis on why people get sick when they have sepsis and why some people get more sick and why less, some less. Then we'll be looking at the spectrum of disease presentation, which is basically the bulk of the topic, but then all of them are individually big topics on their own. So we're only looking at the main highlights of those presentations, and then how to diagnose, how to manage, and what are the complications that we are often sort of dealing in these sort of subset of patients in the ICU. So why do we need to know? It's the second most common infectious etiology, most common prevalent infectious etiology for all the patients that get admitted into ICU from infection. The most common is obviously pneumonia, and this comes second to that. It's unique in that it is sepsis at the end of the day, so whatever we need to do for sepsis will be needed in this situation as well. But what is unique is that without rapid and definitive source control, everything else that you're doing to deal with sepsis, like antibiotics, fluids, inotropes, organ support, it's not going to work, which is a bit different from, say, pneumonia, where it is sort of buying time for things to, stabilize. So source control is vital in this patients, and still, despite everything that's happening, the mortality for patients in intensive care is still close to about 25%. Again, that depends on the etiology, obviously. Like, for example, if you compare someone with an appendicitis who's had an laparotomy and appendectomy versus someone who's had massive bowel ischemia or an anastomotic leak, it depends on the etiology of what the source of the sepsis was. Obviously, it also depends on what was there in their belly. Was it blood? Was it bile? Was it feces? Again, it depends on that as well. As the intensive care has progressed a lot, so we are these patients who actually get better, and they do survive the initial sepsis episodes. Then they get discharged. So they get discharged to the ward. A few of them even get discharged to home from hospital. But then these patients, they develop very often, depending upon the severity of the initial septic insult, they develop some sort of chronic critical illness, chronic intra-abdominal sepsis, from which it is difficult to get better completely, and it's difficult to go back to their baseline. And that actually leads to quite dismal long-term outcomes. And patients in these categories, they usually 40% of them, they die at the 1 year from after discharge from hospital. And the other thing is, as you might know already, we see a lot of it in our ICU here. So classification. So two ways to classify it: community acquired versus hospital acquired. So community acquired is someone presenting to ED with abdominal pain, has a degree of colitis or appendicitis. Simple, so antibiotics, an operation if need be, or just antibiotics would suffice. Hospital acquired is something that's revolving in the hospital, like someone who's had an elective operation and then has had an anastomotic leak, for example, and then they develop sepsis. So that's the hospital acquired, which is more sort of complicated bit as well. Again, you can also divide it as complicated and uncomplicated. It's complicated, uncomplicated again is something like which is localized, which is just one organ, whether it be appendicitis or cholecystitis, for example. Complicated is, again, you can classify it as localized and diffuse. So localized is just a local abscess. You can deal with the abscess and then source control will be done. diffuse is the peritonitis, which we often see on the unit, whether it be fecal, fourth quadrant peritonitis, or even something which is sort of not fourth quadrant, but still widespread, which is what we see more often. We see more often these sort of diffuse, complicated ones, because these are the patients who become more sick and are unwell, needing to come to intensive care. So the peritonitis, again, we can classify it as primary, secondary, tertiary. The primary is basically SBP, spontaneous bacterial peritonitis, which you might have seen. Patients are there on wards as well, especially in decompensated in liver disease, which can cause decompensation. The other causes of primary peritonitis would be ascites in someone who's got collagen vascular disease, for example, or some sort of glomerulonephritic pathology. So usually don't need intensive care unless in the case of a cirrhotic where SPP has happened and caused some decompensation. And that's a different story altogether. Secondary, and then the thing about the primary is that is usually monomicrobial. So there's only one bug. It could be a gram-negative like E. coli, or it could be gram-positive like Streptococcus, but usually monomicrobial. So antibiotics is probably the mainstay of treatment. Secondary is more tricky. So these are all the patients who have problems in hospital from different varying pathologies and causing them becoming septic. And usually the microbiology in this case is polymicrobial. It's a combination of gram-positives, lots of gram-negatives, lots of anaerobes. And again, the mainstay is usually surgical management in addition to all the sepsis stuff. Tertiary peritonitis is, again, something which you will see mainly in intensive care units. So these are patients who have source control, who have up to antibiotic therapy, all the resuscitative efforts relating to sepsis, but then they still have lections in their, in their abdomen, which are there despite all of this. So these are the patients who have at high risk of developing multi-drug resistant bugs. So when you're dealing with these patients, and you have to sort of change the track in terms of what you want to do from an antibiotic point of view. Like you might have to broaden the spectrum, take advice from microbiology, and maybe cover things like MRSA, VRE, or ESBL producing gram-negatives and things like that. So the common causes of secondary peritonitis, which is what we often see top to bottom, and I've included esophagus because if there is an esophageal pathology that is happening at the gastroesophageal junction or the lower third of the esophagus, it's not uncommon for it to cause peritonitis in addition to the mediastinitis that it usually causes. So Boerhaave, trauma, stomach and duodenum, peptic ulcer perforation is a classic presentation, which you see very often. And then there is malignancy and trauma, biliary, so cholangitis, cholecystitis, which can cause ascending infections and affect the liver for causing abscesses. Pancreas, again, pancreatitis is quite common. And it can cause problems if it becomes severe and causes collections in the abdomen. Small bowel and large bowel, basically, malignancy, perforations, anastomotic leak, gut ischemia, they are the common ones. And coming to sort of gynae causes, so anything which is to do with uterine issue and adnexate causing pelvic inflammatory disease. Again, it's important cause if it sort of goes wrong. The other problems that other pathologies that we have to keep in mind is something like TB. Because TB can actually affect anything and everything in that. And one common theme which runs across all of these causes is the iatrogenic element, which is something which we have to deal with quite often because procedures are done in patients' best interest. Sometimes they do go wrong. So you will see those as well in the ICU setup. So coming to the microbiology of all of these, as I said, primary peritonitis, usually monomicrobial, say they're gram-positive or a gram-negative, easy to treat. You target the antibiotic towards that bug. Secondary peritonitis usually tends to become polymicrobial, so you have to broaden the spectrum to cover anaerobes, aerobes. So it's usually something like E. coli along with Bacteroides, which is an anaerobe. Sometimes Clostridium also can be in that mix. And if you see and compare primary and secondary to the bugs that are responsible for the tertiary peritonitis, you see bugs like Acinetobacter, which is quite resistant, organism, it's gram-negative, it's quite resistant, really don't want to deal with it in your patients. And things like Candida and Staphylococcus, some of which could be MRSA, and Enterococcus, and some of which could be VRE. So the knowledge of these bugs causing problems in hospital-acquired intra-abdominal sepsis is important, because you will have to take these into consideration when you're making plans on the ward round about changing antibiotics. And that's where this is where it all comes from, when someone chooses to start vancomycin, someone who's got, who's not getting better with intra-abdominal sepsis. So the gut bacteria as such, they're not bad, they're actually beneficial, and there are a lot of them. They are needed to maintain the barrier function of the GI tract. You really don't want to, destroy all of them with antibiotics, because they are needed. They're important for immunomodulation. They're important for metabolism in the form of intrahepatic circulation, and their presence actually prevents the overgrowth of pathogenic microbes, which is very classic when you see things like C. diff infection, usually associated with long-term or even shorter-term antibiotic use, is probably sometimes unnecessary. Then the common, bugs that are there in other parts of the gut are, they change when you go from stomach towards the colon. So the stomach is usually H. pylori, because that can survive in the acidic environment in the stomach. And there are other bugs like Streptococcus candida, which again can survive in stomach. Candida actually can cause ulcers as well on its own. So then down, everything which is there in the proximal small bowel is almost sort of similar to what is there in the stomach, because it's closer. And then as you go down, the contents in the bowel become more and more alkaline, and that they all favor the growth of gram-negative aerobic bacteria like E. coli. And then when you go from distal small bowel to large bowel, there is a transition from aerobes to anaerobes. So 60 to 70% of the bugs that are there in colon are anaerobes, mainly bacteroides. So just a brief overview of what the pathogenesis is. So any one of these patients with intra-abdominal sepsis, when you see them either in the ICU or in ED, and especially if they are sort of delayed presentation of 2 or 3 days, they will be very, very unwell. And the reason they're unwell is that they are in this sort of profound hyperinflammatory phase in the first few days, where the body is sort of trying to mount an immune response. And that immune response is necessary to control the infection, but very often it just goes into overdrive as well, which causes them to have typically a cytokine storm with lots of interleukin-6 and TNF-alpha and all these sort of pro-inflammatory mediators released into the bloodstream. And that actually abates is typically around sort of 4 to 6 days time. That's how this starts to wane away. That is probably the phase where patients do need a lot of organ support as well, along with source control. And then as the days progress from there on, if it is something which for which source control was done well and there was no more problem, the patients will, recover. But if that doesn't happen, or if that doesn't happen completely, then they go into this sort of small rings, insidious phase of chronic critical illness, where they are not as unwell as they were in the first few days, but still they're not really happy end of bed when you look at these patients, because there is something still not completely right with them. And then in this phase as well, there is profound immunosuppression, because the body's immune system is possibly tired by that time. So there is a degree of almost immune fatigue which can happen. So the body is not able to mount that response. And in that phase, all of these secondary infections tend to happen. So there is immune fatigue, there is apoptosis of various immune cells, so you don't have effective immunity, and then the patients are exposed to secondary infections, which can lead to and ultimately a poor outcome. So spectrum of disease, so this is probably what we see here on a day-to-day basis. You probably would have seen a lot of these if you worked here for a few months. Polyviscous perforation like DU perf, or small bowel obstruction called perf, anastomotic leak in post-op patients, solid organ abscesses, probably a bit better than others, because we probably wouldn't see them that often, but every now and then there is, a liver abscess that goes when patients become unwell and need to come to us. Then cholecystitis is quite common. But what is probably important is that we need to keep in mind not just the gallstone-associated cholecystitis, which we all probably are familiar, but the acalculous cholecystitis is more dangerous, especially in the subset of patients who get admitted to intensive care. So that's something you probably should be keeping an eye on and keep it in the back of your mind, because it has high mortality if it goes unnoticed. Then mesenteric ischemia basically is gut ischemia. And pancreatitis, we don't see it that often in this unit, but every now and then there is a patient with acute and chronic pancreatitis that becomes unwell. C. diff, again, we do see it. Unfortunately, I would like to say less often, but we do see it every now and then. Okay, so that's the spectrum of disease presentations that come to intensive care. Now, how do we diagnose? So obviously clinical assessment, that's probably the most important thing, because that is what is going to lead you into investigating further, or have a high index of suspicion and have a chat with surgeons sooner rather than later. Obviously, blood investigations, FBCs using is the usual ICU lot along with lactates. Fungal biomarkers are actually important as well for when you're dealing with these. You do send beta-glucan on a regular basis, isn't it? And then other things that can aid in your diagnosis is CRP, procalcitonin, and then cultures, almost pan culture, whatever you can, really, blood, pus, urine, brain fluid, stool. Radiologically, the diagnosis that the investigations that you would need is starting with chest X-ray, and ultrasound, but obviously the investigation of choice with intra-abdominal sepsis is CT with contrast. CT without contrast is meaningless. You will not get any information from it. And very often we give IV plus oral contrast as well, whether it is orally or with an NG tube. Okay. I'm not going to delve on the clinical assessment too much, because obviously abdominal pain, tenderness, fever, they're all sort of common presenting features in this. Now, fungal biomarkers, you're all familiar with it. We do it all the time. Beta-glucan, galactomannan. Why do we do it in intra-abdominal sepsis? Why do we do it as a routine for all the patients that have this on our unit?
It must look quite similar to a bacterial or viral infection, otherwise you'd use clinical judgment.
Mm-hmm.
They're here, so they've been unwell for quite some time already, and antibiotics might not have been working.
Mm-hmm.
The treatment won't work on the beginning of the infection, so we need to know if it's fungal.
Yeah. And then why can't we just wait for culture results to come back? Then why do beta-glucan? So fungal culture usually takes longer to become positive than compared to bacterial cultures. The one important benefit of doing beta-glucan is it has a very high negative predictive value. If it is negative, it means that you don't actually need to give antifungals to these patients. The turnaround for this test is quite quick. Here in LRI, we do it in, I think, 2 batches, one on Monday and one on Thursday, just because of the way that the test needs to be done. But the turnaround time on the day that it is done is quite quick, so you will get the results quite quickly. But the important thing is that it has a very high negative predictive value. It's culture-independent test, and it will therefore help you in guiding into antifungal therapies. But the thing with that is also that there is a degree of false positivity that can happen, and you have to put that in clinical context. So, for example, if patient is on a filter, or patient has some sort of gauzes and surgical fungus inside, that are there for a reason, or patients receive some things like immunoglobulin or albumin, there is a degree of false positive beta-glucan that can happen in those patients. So you have to put that in the clinical context. Very often the recommendation would be that you repeat it again and see if it's sort of stayed static or has gone up, so that it will give you an idea of where we are with that.
What does galactomannan add? So
galactomannan is specific for aspergillus. So beta-glucan also can identify aspergillus, but galactomannan is more specific for aspergillus, whereas beta-glucan is more for everything, but basically Candida. Okay. So, Dr. Talking, feel free to shout what this could be. Not a test, you can say whatever you want really, and then we can take it from there.
So it looks like it's around the liver.
There are lots of pointers to help you, so, or you can just look at them.
Looks like read the
Is that fluid? Who says fluid? Who says air? So anything black is air. Would we expect that around the liver? So that's abnormal. What about this picture?
looks like
Something puff, water's puff. Bowel puff. So this is a perforated duodenal ulcer with pneumoperitoneum. So the treatment with that would be fluid resuscitation, but immediate surgery. A mental patch. Usually they do a washout, they're doing a mental patch. They come to us, they have omeprazole for 48 hours, they have usual broad spectrum antibiotics plus antifungal. It's important to keep a close eye on fungal infections here because candidal sepsis, especially intra-abdominal candidal sepsis, is quite common when the pathology is more in the upper GI tract. So anything linked to esophagus and stomach duodenum, you have to have a high index of suspicion for intra-abdominal candidiasis. Okay, usually, unless the patch falls off, these patients, their recovery is quite straightforward. They stay in the ICU for 3-4 days, and then we end up sending them to the ward. Okay. What about this? Which one? So which one?
Right.
Are you worried about both?
Well, I am because that isn't the one on the left doesn't really look like a gastric problem.
Okay.
But definitely on the right.
Definitely on the right.
That's definitely.
Definitely on the right. So what if I say that this patient had an operation like a couple of days ago?
you can get evidence.
You can get air after the laparotomy. So if it's a post-laparotomy and the patient is clinically okay, then you probably have to take that in the context of post-laparotomy change. If it is not, and if this is a patient that is there in ED, then obviously that is worrying. The air under the right diaphragm, as you rightly pointed out, is more serious. The left one, you have to take it with a pinch of salt because it might still be a gastric bubble. Okay. What is this?
Pancreatitis.
Mhm.
Has the gases or layers.
Is it
Abdomen.
I'm in the outfit.
Abdomen. Yeah. CT of an abdomen. I mean,
I meant to check in my head.
it's difficult to tell what it is on just looking at one cut. Yeah, so I think that's pancreas. It's a bit low down for pancreas, I think, because you won't be seeing these bones, isn't it?
That's
Okay.
covered by, so it's going to be
One of the patients who was with us a few months ago, that's appendix. I mean, it's not supposed to be as big as this is. The CT reported that it's, I think, quite long, and obviously you can see that probably perforated as there's some air around it. So this patient was very unwell and needed a right hemicolectomy and myocardial stenosis. Okay. What about this?
So with the same space, it's around where the rectum goes down, isn't it?
So what's the black arrow? What's the white arrow?
Is white arrow some kind of leak, a contrast leak?
White arrow is contrast leak. Yes, agree. And the black one? That's probably just extraluminal because you can see it outside as well. All of this. So this is an anastomotic leak in large or possibly sigmoid colon, concerning where the arrows are pointed basically. Okay. What about this? I mean, that gives away anyway. So that's a pelvic abscess. So the thing with pelvic abscess or any other abscess is what you're interested really to know is, does this patient need a laparotomy, or can you put an ultrasound guide or CT training? All right. It's obviously has the hallmark of an abscess because it's got this enhancing rim, and it is quite close to the surface. It's possibly amenable for percutaneous drainage. Okay. What about this one? That's the liver abscess. And again, very often the treatment for liver abscess is antibiotics plus, if the abscess is small, say less than 5 centimeters, you can just aspirate it. Or if it is more than 5 centimeters, it needs some sort of.
What if it's like hydrogen cysts?
Yeah, I'm coming to that. All right. So if it's more than 5 centimeters, obviously it needs a pigtail drain, ultrasound guided or CT guided. Very, very rarely do these patients need, exploratory laparotomy and resection of the affected liver segments, but can happen if it's quite extensive. Now, what are the other organisms which can cause abscesses in the liver? Klebsiella. Yeah, this could be Klebsiella. I mean, apart from bacteria.
Oh, you get fungal abscesses, can you?
Can happen, yeah. More common, I mean, not always.
SORS. Yeah, SORS. That's the woman.
What is that?
SORS.
Okay. Anything else? Any big abscess. It's not that common in this country, but people have traveled from abroad. You must have seen them asking the question quite often. Is there a travel history? Have we done a stool test for anti-labor? So any big abscess. Hydatid. Does it form an abscess?
Cyst.
It's a cyst, isn't it? It's more of a cyst rather than an abscess. So what would you do if it's a hydatid? Have you seen any so far in your any time? I've seen, a few back home in India, but I've seen one here. The patient presented with anaphylaxis. So yeah. So the only presenting symptom which was quite sort of evident was anaphylaxis, swollen lips. So radiology consultant who traveled but long time ago. Probably she had this in her for some time and then it ruptured and then caused some pain, but then it caused lots of anaphylactic symptoms like lip swelling, and there's not a change in voice, but the lip swelling and a bit of rash was very evident. So the treatment for that would be obviously albendazole for a really long time. Sometimes they might have to give albendazole into the cyst as well to prevent this from happening. But yeah, that's again an organism. You have to take proper travel. So history from the patient to understand whether. But if it is an abscess and if it's some sort of weird anaphylactide, probably that should be quite high on your mind. Again, ethnicity and things like that would play as well a role in diagnosing that. Okay, what about this? You're still in the abdomen. Which is the kidney? That's the kidney, I think.
So I'm just thinking, is that another kidney on the right that just looks awful?
You think that's a kidney?
It doesn't look like a kidney.
It doesn't look like a kidney, yeah. What could it be? Usually the left kidney is slightly higher than the right, isn't it? What do you think that could be?
Looks like a
Didn't that look like an abscess?
Probably. What is this, you think?
Is that part of a bowel?
It's a bit solid for bowel.
liver.
Liver, yeah. So that's liver. So if that's liver, what could this be? Huh? See, you're getting there. So it is gallbladder, and then you can see some stones as well. Okay, so this is cholecystitis. And there is very typical sort of thickening of the wall of the gallbladder as well that you can see. Wall is quite thickened. All right. So the treatment for this would be antibiotics, and if the patient is stable, if the cholecystectomy done, either within that admission or they go home and then come back when they're a bit more stable. But cholecystectomy would be the main go-to thing there. Then what is this? It says gallbladder, but what is this?
Is it? Looks like a wall. Has something wrong with it. So is it some kind of communication between the gallbladder and the liver?
Oh, that's the liver, that bit there. That's the liver, obviously, because the gallbladder is underneath it. So what's the difference between the earlier CT scan, where you saw the gallbladder, and this one?
Oh, there's no stones.
There's no stones, and the gallbladder looks a bit distended. But equally, they've said that the gallbladder wall is about almost sort of 5 millimeter thick. So this is quite classic for acalculous cholecystitis. We need to know this because in intensive care, when patients are unwell from any other reason and are not able to maintain adequate oral intake, they're septic from any other cause, or they're on TPN, then they are prone to acalculous cholecystitis. So the classic thing which happens is altered LFTs, raised ALT, phosphates elevated, but we don't see any large amounts. Easy to diagnose bedside with an ultrasound because the thickening of the gallbladder wall without any stones is what we're basically looking at. Can be diagnosed with CT as well. Now the thing about this condition is that if you miss it, and if you think that there is something else happening, the mortality for untreated acalculous cholecystitis is very high. Especially if this gallbladder ruptures, then you're just dealing with biliary peritonitis, and the patient will be very, very sick.
Is this just treated with antibiotics, or would they ever have a hot cone for it?
So this is treated with antibiotics, and the treatment of choice for this condition is placement of a cholecystoscopy drain, which is either ultrasound guided or OCT guided. That is the treatment, because given how unwell these patients are, especially if this happens more often in the context of critical illness evolving in the ICU, it's quite difficult to subject them to a cholecystectomy. So the treatment of choice would be to put a drain in, decompress it, and then see what you want to do. If the patient gets better, then they can have a cholecystectomy at a later stage. But the patient, if they continue to be unwell, then just leave the drain in for longer. And sometimes they will do sort of a tubogram via the drain to see where they are, and they will just consider taking the drain out if it starts to dry out, or then they subject the patient later on to a cholecystectomy when more stable, but leave the drain for a bit longer. But again, antibiotics. So TPN will predispose patients to this complication. It doesn't happen that often, but you have to keep this in your mind.
Why? Is it to do with cholecystitis?
Yeah, because you're not feeding, yeah.
Investigation of choice is still ultrasound.
Still ultrasound, because CT, these patients are usually unwell, and you can actually diagnose it with an ultrasound fairly confidently. You can do a CT for confirmation. Previously, they used to do HIDA scans for it, but I think that's starting to go out of fashion nowadays. Okay. What is this? Again, I comment.
Is that calcium stones near pancreas?
Can you see pancreas? I can't see pancreas. So, I mean, there are two arrows, there and here. But I can't, I'm not the best at radiology for CT abdomen, but I can probably be confident that I can't see the pancreas here. What this is, the bowel wall is sort of thickened. And the same here, all right? So this doesn't have any other features, but this is bowel ischemia. So classically, thickening of bowel wall. These are more subtle signs, which mean at our level, as working in intensive care and intensivist, we don't need to probably pick all those signs. But those are the questions you might have to ask the radiologist at some point if you ask them for an urgent report. So the classic signs are basically this, just thickening of the bowel wall, but you can also see some gas locules within the bowel wall. And obviously, if you do an angiogram, CT angiogram, then you can actually sometimes delineate why it is. So the bowel ischemia or mesenteric ischemia can be acute, it can be chronic. The chronic is probably less of a bother to us because it's probably, someone who's got atherosclerotic disease and it's just sort of happening patients classically with chronic centric ischemia, they complain of pain after having a meal, because that's when they're challenging their gut. Acute ischemia, acute mesenteric ischemia is usually, it can be embolic, which we see quite often here. It can be thrombotic as well. It can be venous, which causes lots of engorgement, and then it can be just non-occlusive, nothing sort of occluding, but you're giving the patients lots of noradrenaline, lots of vasopressors. You're actually causing a lot of squeeze, compromising the intestinal circulation. The one benefit that the intestinal circulation has is that there is a lot of collateralization. So between the celiac, SMA, and inferior, there is a lot of collateral supply. So it is actually tolerant of a lot of insult. But depending upon where this clot, whether it's thrombus or embolus lodges, that will dictate the future course of the patient, because that will then affect the extent of bowel that's involved. And usually the treatment would be, you really need a high index of suspicion to diagnose these, and CT angiogram is the investigator of choice. But the treatment would be laparotomy, taking the affected infarcted bowel out. Either they get joined straight away, or then they come back and then they go for an interval laparotomy 48, 72 hours later. If it's a thromboembolic etiology that we have identified, then these patients will need anticoagulation as well as a systemic anticoagulation, which makes it a bit more tricky. If it's a non-occlusive, then you obviously have to see how you are modulating your vasoactive inotrope support. I mean, are you actually increasing the flow, or are you just doing the squeeze? That's the thing that we need to sort of make a decision. Okay, what is this? Or just sort of focus on where the arrows are, then tell what it could be. Small bowel, large bowel. Large bowel, because there are arrows here, there are arrows here. Probably this is ascending colon.
So elsewhere you can see contrast.
Yeah.
Arrows, no contrast.
Is it like obstruction?
Probably not obstruction, because you can see contrast here, but then there is some here as well, so maybe not obstruction. I mean, again, you see classically that this bowel wall is a bit thickened when compared to the others. So colitis. This is C. diff colitis, but then more classic presentation of C. diff colitis is a megacolon, where you can see more than sort of 6-7 centimeters of ascending colon, almost at the verge of rupture. Polytoxic megacolon. In this case, that is not the case, but you can appreciate that again, the bowel wall is a bit thickened.
So it's that, the white areas that look like they've got contrast in that.
Yeah.
That just because we're just looking at a thick bowel,
Yeah,
and not looking
yeah.
at the lumen.
Yeah,
Right.
it's not a luminal problem, it's a wall problem. Very often these patients, if they are subjected to an endoscopy, which we don't do it normally, they will have a pseudomembrane. The treatment for C. diff is usually, as you know, it's oral vancomycin plus minus metronidazole, because IV vancomycin will not work. Oral metronidazole is the best, but IV can work if you don't have any other options of oral vancomycin. And again, the main risk factor here is antibiotic use. So if the patients have been exposed to antibiotics in the last couple of months, this is quite high on the index of suspicion. And these patients become unwell, they have the toxic megacolon very often on the CT. They'll also have profound leukocytosis on the investigations. The last thing you want is for it to rupture, because that will make the patient really, really sick and possibly will lead to death. The treatment, if you've got toxic megacolon, is basically total colectomy. What is this?
No, it's that, the pancreas.
That is the pancreas.
Yeah, I was going to say it. They're going to think I'm in love with pancreas.
So that is pancreas. It's necrotizing pancreatitis. Mainly, if you see the head, the body of the pancreas, it's not enhancing as the tail. Okay, so that's basically non-enhancing and it is necrotic. Okay, fairly common, happens around sort of 3 to 4 weeks when you're dealing with pancreatitis patients, especially when they need intensive care. Happens not in all of them, happens in about 20-25% who who are these sort of a lot that need to come to the ICU. So the question here would be, are you going to be giving this patient antibiotics or not?
So it's all the enzymes, isn't it, that cause the damage?
Yeah.
But then you've got a risk of infection of that. So yes.
Do you want to give antibiotics here? It's not a leading question.
Oh, it's necrotizing, you would.
You would?
That was my understanding.
Okay.
If I don't try to.
I think we should fix that every secondary infection,
Okay. Is there secondary infection?
not radiologist.
So that is the question that you have to ask the radiologist, isn't it? Sometimes you don't need to know the knowledge of the CT scan, but you still know what to ask so that they can, if they can have another look and tell something useful. You don't need to know and identify it.
So in practice, to these people, if they don't have evidence of secondary infection on the CT scan, you wouldn't give them antibiotics.
Now, the problem with pancreatitis is that once you admit someone with pancreatitis to ICU, not going to get it off so soon. They're going to be staying for weeks and weeks. You will see this in ICUs who have capillary input. They're there for a very long time. And the thing that you should have in mind is not exhausting your antibiotic options sooner, because you'll very soon run out of options. The question to ask radiologist is this infected? Now, what they're going to look at is there any gas? Is there any air in this revitalized necrotic pit? So is there any black spots that I can see? That's what they're looking at. And if there are none, they can be quite positive that probably infection is not a concern. Obviously, you have to take a clinical take on that and make a call in terms of whether you want to give antibiotics or not. But if the patient is sort of okay and not spiking temperatures or not becoming hypotensive, because this usually happens in 4 weeks. So by that time, all the acute pancreatic phase would have sort of slowly withered away. So if this patient is not showing any septic markers, then you probably should investigate further, maybe do a procalcitomy, see where you are, whether this is infection or not. Look for the CT scan. And if the patient's okay and there's no evidence of gas, there's no need for antibiotics. And you just, sit tight and monitor. What is this? Is it normal or abnormal?
It looks abnormal.
It looks abnormal, yeah.
It's that weird bit on the left-hand side.
That one, yeah. Is there anything else abnormal on the CT?
The bowel, yeah.
That's abnormal, you think? Okay.
It's swelling.
And the air.
Okay. But you really can't tell at this point whether the air is within the bowel or outside, isn't it? So you can't make that out just on this cut. Is there anything abnormal apart from that and this?
Oh, there's a weird thing looks in sort of slightly to the left of the width.
Here?
Yeah,
Here?
slightly up there. Yeah.
There. Okay, so that's abnormal. Take it. Yeah. What is that?
It looks similar to our abscesses and cysts earlier, so I'm assuming it's some kind of fluid-filled thing. It could be extravasation.
So that's, again, pancreatitis with lots of peripancreatic collections. So pancreatitis is quite complicated to deal with, which is why they end up staying so long in ICU. They have all of these issues with collections around the pancreas. They have collections which become infected. They have collections which actually compress, sometimes the edges and viscera. They also have lots of inflammation happening around the pancreatic tissue, which can cause, sometimes thrombosis of the, splenic vein thrombosis and things like that are quite common. So this is a peripancreatic collection here, and that as well. Okay, so this is proper acute, severe acute pancreatitis. Maybe, there is grading, radiological grading of pancreatitis, but this will probably be grade 3, grade 4. Okay, so, but again, how are you going to deal with this?
No antibiotics.
Drain it. Okay, so these patients need sort of ultrasound guided or CT guided drains. I think probably CT guided most often, pancreas is peritoneal, and those drains stay for a really long time. In the ICUs where these patients are being managed, you have to keep a close eye in terms of what's coming out of the drain and the drain output and see where we are going. Sometimes they form a pseudocyst, And then the way to deal with the pseudocystole is to basically decompress it into the stomach. So patients have an endoscopy, and then you can go through the stomach into the cyst and put a stent in so that you can decompress the cyst into the stomach. The stent is obviously, removable stent. It's not going to stay there forever. So that's, a snapshot of what we usually deal with. In terms of managing, I mean, the usual sepsis stuff is important. So fluids, antibiotics, organ support. And then if the patients are in a refractory shock, despite expressors, obviously steroids have a role. So nothing unusual from anything else. But then because everything is to do with abdomen, nutrition is key. You should not be sort of left behind just because of the. So day 4, day 5, you think this is not going to resolve soon. Maybe you should sort of resort to TPN in the short term before leaving the patient, without any nutrition for any longer than that. And then source control is the key. I mean, without that, everything will not succeed. So whilst these patients, when they are in their profound hyperinflammatory phase, they need a lot of fluid. You need to keep a close eye on how much you're giving them because they are at risk of abdominal compartment syndrome. So you have to sort of take a judgment in terms of are you giving too much? Or do you think you can sort of see whether the patient is responding? So you can do things like echo or passive leg raising to see the fluid responsiveness. But obviously, given that they are in the hyperinflammatory phase, they will need a lot of organ support. So all the cardiac, ventilatory, renal support at this stage. And then slowly after sort of day 6, day 7, things start to sort of settle down, and then there will be some improvement in blood pressure. You will be able to come off and wean off the reactive supports gradually. If they don't have any sort of hospital-acquired pneumonia by that time, ventilation is usually not that big an issue. Renal replacement probably can go on for long because AKI will take slightly longer to resolve, especially if it has needed dialysis. So antibiotics, in addition to source control, as I said, are one of the important mainstays in this treatment. Obviously, we discuss with micro, refer to local trust guidelines, but always keep in mind in terms of what actually you're dealing with, what is the pathology, and then ask those important questions to the microbiology, either the registrar or the consultant when you call them, because they're not seeing the patient, they're looking at the test results. So you have to sort of fill in and give them the other part of the story so that they can help you with proper guidance. And as I said, fungal biomarkers, antifungal therapy, fungal biomarkers are important. So risk factors for fungal infections is basically someone who's on steroids, immunocompromised, multiple comorbidities, a long hospital stay, multiple operations, they're all at risk of fungal infections. So source control, obviously laparotomy is best if it is needed, but then there are a lot of other things that can be done if you think that they are the best ways dealing with this, because even the sepsis guidelines say that if you do source control with minimum physiological interruptions, it is possible. So percutaneous drain placement is the best. But if it is not going to happen, then laparotomy. Sometimes if the patients are very unwell, then damage control laparotomy and return to theatre and do it like a stage approach, which you see quite often on our unit here. But in all of this, understanding what the surgeons found during the operation and communicating with the surgeons is key, because they will be the persons, the doctors who will be able to tell you what actually they're worried about, because you might not know that where you just examine the patient. And also looking at the op note and understanding it, and if you're not clear, then having a chat with the surgeons on why is this happening and what is the main concern. So that's vital so that you can have a positive outcome. Recognize this?
Looks like an open.
It's an open abdomen. And what's the? It's a vac dressing, okay? And fairly common. It prevents the development of abdominal compartment syndrome, especially when it's difficult to close, so the fascia is left open, vac dressing is placed. There's a vacuum negative pressure as well, so all the collections and fluid can drain out, and the surgeons can actually go back in 24, 48 hours to have another look.
Just my understanding, so the vac is underneath, and then they have this clear dressing on top.
Yeah.
Right?
That is to enable the negative pressure firmly seal it. Okay, so complications. So obviously recurrent collections, obviously falls into the tertiary peritonitis type of category. But when these patients have operations more than once within a short period of time, their abdomen becomes more and more hostile. And that could be the reason why the surgeons would not want to actually go back in, because if they go back in, they'll possibly cause more damage than cause any benefit. And that can actually lead to patient's death as well, if that is where we are. Obviously, fistula formation with recurrent surgeries is quite often seen. And most often there are sort of enteroenteric fistulas between different bowel segments. There are fistulas that develop in other visceral organs. Sometimes fistulas develop to the atmosphere as well. Now, these patients, whilst some of them, when they start to sort of get a bit better, as I said earlier, they do go into this chronic critical illness. So they go into this big state wherein it is persistent, immunosuppressive, catabolic syndrome state, wherein the chances of them getting nosocomial infections and deteriorating further is very high. All right. So this is a case scenario from our unit. So 75-year-old man, emergency laparotomy, so small bowel perf. This was a jejunal perf. Had 4-quadrant peritonitis. Went to theaters. The patient was on the ward actually when this happened. So went to theater, had a washout. They've done bowel resection. They've done a primary jejunal anastomosis and came back to us. He was in multi-organ failure, so he was in this phase in the first few days. So he was on a bit of vasoactive support. He was ventilated. He had AKI, but he didn't need dialysis. Then he slowly got better. So he sort of reached around sort of this phase wherein AKI resolved, vasoactive support resolved. He was essentially a single organ. He was on CPAP AAC, but he was very weak and deconditioned by that time. And he's 75. He was, I think, was hypertensive. So he was never in a state fit to be extubated. So he got a perk trachea done. And then around the same time, one of the cultures that we sent in the early phase came back. And he was positive for Candida. This happened whilst he was already on some antifungal medication. So we changed the antifungal according to micro advice. We started to slowly wean him off the ventilator. But around sort of 2-week mark, he had this drainage of bile from one of the abdominal veins. There was some pus coming from the midline abdominal wound. There was some bowel content and bile coming from the abdominal veins. Patient himself was clinically okay. They were not needing any vasoactive support for all of this. They looked all right. We were weaning them. They did not need any other organ support. They were progressing well on their respiratory wean. But we did do a CT scan around that point, and it showed discrete collections around the liver, around the spleen. But the jejunal anastomosis was intact. So the surgeons and us, both of us, we felt that given the patient was already deconditioned, he was actually clinically unwell. The feeling was that we should just sort of carry on conservative management with continuation of antibiotic therapy. And the patient was all right on that for some time, and then we decannulated him and then sent him to the ward. When we sent him to the ward, we felt that this man did have, what we call as chronic intra-abdominal sepsis, because there was still these collections around liver and spleen. Okay. So what do you think would have happened with this patient?
Can I ask a question?
Yeah.
What is drainage into the peritoneum?
Which one?
You said so. Day 15, drainage of bowel content from
It was an abdominal drain which was done. It was there as part of this operation. Right. So when they did the initial operation, they left some abdominal drains. That was the drain that was starting to drain bile.
Just confined it to the gutter.
Yeah.
Would you not be worried about perforation at that point if you're getting bowel content?
Well, there was no leak anywhere, and there was no evidence of free air on the CT scan. The only positive was this collections. Okay. There was no free air on the CT.
Okay.
So what do you think would have happened with this man? He's probably somewhere here, isn't it?
So he's risking a secondary infection developing.
Yeah. So he developed further nosocomial infections. He became unwell within a couple of days of discharging to ward. When we sent him to ward, we did sort of put a plan in place that if things were to go wrong, and given that there were no surgical options, we would not readmit him. But obviously, he can have all sort of ward-based care, including antibiotics. Then he became unwell enough. All this while, he was actually conscious, and we were able to engage him in a conversation. So a respect-formed conversation happened with this patient, and sadly, he passed away within a few days. So chronic critical illness does exist, and probably more than what we see. Because very often we don't know what happens to the patients that go from here to the wards. But it probably happens more often because more and more of these patients are surviving.
It's a recent patient.
It was a couple of months ago, possibly September.
He initially had an Lewis.
Yeah.
Yeah. He died.
Okay.
Patient I saw. I always kind of like that. I knew that he wasn't doing well when he left, but I really hope that he made it.
Yeah, that one. I didn't include the other bits because that was not the problem.
He read it as that.
Okay, so take home is basically timely diagnosis, antibiotics, source control, imaging sooner rather than later, antibiotics based on presentation, and always source control. Especially when you're, on the night as the registrar and you see these patients in ED, not often, but very rarely you come across scenarios wherein the patient is very unwell and the surgeons do not want to do anything because they think the patient is too unwell. I mean, which is fair, but then bringing the patient to ICU and offering resuscitation support is not going to make them better. So whilst we sometimes agree to do that, that should not be the usual practice. There always has to be a dialogue with the surgeons on how soon this patient can go to theatre. We are going to support him, but the support is going to be useful only if the main problem is dealt with. So whilst you're okay in the rarest cases to admit someone who's peri-arrest and resuscitate them aggressively in ICU, but the usual norm should be that they go from ED straight to theatre and then come to us. Okay? This is the important bit, feedback.
Thank you very much.
Thank you.
Really good.
I have any crazy. All right. Hope it was useful. Stop sharing.
I really like the CT scan.
Yeah, I really enjoy
Really
that.
nice. Oh, sorry.
And maybe
Otherwise,
let's
it's easy to fall asleep in this.
Well, it allowed us to apply what you just taught us. Really good way, I think.
maybe realize what 4 hour reading CT scans.
All of us are. We can never be experts in that.
And maybe
But-
when I see the report.
But don't be surprised, even for the FRC, I think there is an ICM question that props up at some point in the Viva. I think there is an ICM question, and you might be sort of shown some of these. For the ICM exams, I mean, there will be a lot of these.